speaker. It's a pleasure to introduce Dr. Dewang Angmo, who is an Associate Professor of Ophthalmology at the Jindapara Center for Ophthalmic Sciences, All India Institute of Medical Sciences. She is one of the rising stars of Indian ophthalmology, one of the top clinician scientists who have had wonderful research in the field of glaucoma, including basic sciences and glaucoma surgery, has innovated several new techniques. And today she'll be giving a counter to Nathan on trabeculectomy as the gold standard for glaucoma surgery. So over to you, Dr. Dewang.
Thank you, Professor Tanuj, for the kind introduction. At the outset, I would like to thank all the organizers and Dr. Namrata Sharma and Dr. Barun Nayak for giving me this opportunity. I hope my slides are visible.
No, it's not started yet. This share screen has not started.
So I'll just share this.
Yes, now it is visible. You can just do full screen.
Now is it fully visible?
Yes, please carry on.
So I would be speaking on medically uncontrolled moderate glaucoma, and I am for the motion for trabeculectomy. So coming on to the topic, that is moderate glaucoma. As we all know that moderate glaucoma is clinically defined as having a Cup-Disc ratio from more than 0.6:1 to 0.8:1, and it should have a corroborating visual field defect with a mean deviation between -6 decibels to -12 decibels. So it is very important that this moderate, once the patient comes to this moderate glaucoma stage, they are very, and the patient is uncontrolled, it is very likely that they go into the severe glaucoma stage and eventually lead to blindness. So catching our patient and managing the patient and doing the surgery at the right time is the need of the hour. And the target IOP that is set for these moderate glaucoma patients is definitely between 12 to 15 millimeters of mercury. That is, it is towards the lower side of the lower teens, because that if it is not controlled, it is not at this lower level, it will definitely progress. So if we look into the risk factors for progression, as given by the AGIS study group, they had shown that a higher IOP and a higher IOP fluctuation is a very high risk factor for glaucoma. So lower the IOP, lower is the risk of progression, and lesser is the chance for our patients to go into blindness. So with this, our management for especially the medically uncontrolled patients is to do a surgery, and trabeculectomy, as the World Glaucoma Consensus Statement says, is the incisional procedure of choice, and is better and a more sustained IOP lowering effect, along with being cheap, proven, effective, potentially long-lasting, and acceptably safe incisional option. So as has been described by Dr. Nathan, there are various complications of doing a trabeculectomy. However, with the 21st century safe surgery technique, which uses a large scale FAP, and it also has a large area for the use of antimetabolite, and the antimetabolite that is used is at a lower dose and lower time, and the time is also shortened over a diffuse area, and most of us have shifted to a fornix-based flap. And the use of releasable sutures or adjustable sutures, which can be titrated the very next post-operative day, is a boon to all the surgeons. And nowadays we have all the fellowship trained surgeons rather than general ophthalmologists who used to do trabeculectomy a few decades ago when these major trials were done. And definitely with the better clinical acumen, we have early recognition and management of such complications. So if you look into the literature and look at the treatment of the moderate stage of glaucoma, there are two major RCTs. One is the collaborative initial glaucoma treatment study. So if we look at the main outcomes, we have in this study, in the SIGIT study, patients of moderate to advanced stage of glaucoma were randomized into two groups. One was the initial medical management group, and the second was the trabeculectomy group. So although what they have noted majorly was that a high IOP variability was unfavorable for glaucoma. And next is the advanced glaucoma intervention study. This is another landmark trial in which the patients were subjected, one group was subjected to trabeculectomy followed by laser followed by trabeculectomy, whereas the other group was subjected to laser followed by trabeculectomy and trabeculectomy if required. So again, the major outcome, if you see, they have shown that low IOP and low IOP fluctuation reduced visual field progression in advanced glaucoma. So if you see a long-term study from our center, we look at the yellow bar chart, yellow graph, it shows the progressing eyes, whereas the green graph, which shows the stable eyes. We definitely see that the progressing eyes, the IOP fluctuation is much more, and we have found that the eyes having a fluctuation of more than 4 mm mercuries at every follow-up, they were definitely the ones that had progressed. So coming on to MIGS, that is minimally invasive glaucoma surgery. So first and foremost thing about MIGS is that it is very expensive. So especially in developing countries like ours, where most of our patients cannot afford, this is not the option that we have. Second is that the IOP lowering of these MIGS is in the mid-teens, whereas for our moderate uncontrolled glaucomas, we want the IOPs to be lower than 15, definitely between 12 to 15 millimeters of mercury, so that they don't progress. And it has been shown by major studies that IOP spikes are the most frequently reported complications of MIGS, which is and this again we don't want for our uncontrolled glaucoma subgroups. And the subconjunctival MIGS, they usually have a filter. There is a use of antifibrotic agents. So like trabeculectomy, they do have blood-related complications. So what is the added advantage? So to summarize, I would say that trabeculectomy is cheap, it is proven, it is effective, it is potentially long-lasting, it is an acceptably safe option. And with the 21st century safe surgery technique, the complications are minimal. Whereas on the other hand, we have the MIGS, which is expensive, and definitely it has a limited IOP reduction and has a lot of IOP spikes. The long-term results are still awaited. Therefore, what is the added advantage? If you look at the glaucoma continuum, we look at patients which are early glaucomas. Most of the literature gives evidence that MIGS are useful in the early glaucomas. But once the visual field changes come, which is in the moderate stage, there is a use of the bleb surgery, that is the trabeculectomy surgery, and a very limited role of MIGS thereafter. So my take-home message is that the 21st century safe surgery technique, which is an adaptation of the move field safe surgery technique, that says that trabeculectomy remains the gold standard for IOP lowering, with the ability to titrate downwards with early removal of releasable sutures with minimal complications, whereas MIGS, on the other hand, is expensive and less potent in IOP lowering. And with this, I would like to thank all the audience for the patient listening.